this Tuesday. It is Neurology Morning Report. We're so happy to see everyone. And we would love to have two people to discuss a case, ideally one identifying as a woman and one identifying as a man. And if someone has a case they were hoping to present today, that's fantastic. If not, we have our wonderful neurology teammate, Dr. Doug Pett from UC San Francisco, who has a case. But if someone had a case they were hoping to present today, he has kindly offered to defer to another time because he has thousands of cases. He's a senior neurology resident, thousands and thousands. So let's get some volunteers to discuss this case. Some volunteers to discuss the case. Who would like to discuss a neurology case today? You might be thinking, oops, I thought it was an internal medicine case. Well, neurology is part of internal medicine, right? And I'm sure you're seeing neurology, whatever your field of study is. So you might be thinking, I have neurophobia. I don't want to discuss a neurology case. That's a great reason to discuss. We will reduce your neurophobia, hopefully, through this discussion. Still no volunteers. What else do I have? You might be thinking, English is not my first language. I'm a little bit uncomfortable. We have speakers of Spanish and French, usually have speakers of Portuguese. So you could easily be able to get some translations if you need or have any questions or can't find the word. Still no? Anyone? You're all here for the fun. Somebody has to have the most fun as a discussant. Anyone like to discuss a case? Who would like to discuss a neurology case? Anyone? Everyone's here waiting for you to discuss. You're thinking, maybe next time. Today is the day. Let's do it. Who would like to discuss? Who would like to discuss? My awkward silence, my attempt at encouragement, both failing. Mario, fantastic. Happy to have you discuss. Mario is a repeat discussant. He loves discussing neurology cases. So you see how much fun he has had before. He wants to do it again. Ideally, someone identifying as a woman who would like to discuss with Mario. All right, in the meantime, Mario and Doug, do you want to introduce yourselves? And this might encourage someone to join in the fun.
Mario, you go ahead.
Yes. Hi. Hi, everybody. My name is Mario. I've discussed a couple of times in the Neuro VMR. It's always fun. So happy to be here again.
Great, and we are happy to have you.
Yeah. Hey, Mario, nice to see you. Thanks for jumping in. I'm Doug Pett. I am a fourth-year resident at UCSF in neurology, and I co-host the Consult Question CPS podcast with Lindsay Shipley and Dan Minter, and I am an enthusiastic soldier in Aaron's goal to end neurophobia. Very happy to be here and nice to see you all.
And if you haven't heard the Neurology Consult Question podcast, in which Doug totally stumped me, the diagnosis was one I did not mention for the entire 2 hours that were cut down to 1 hour for podcast. Not that should discourage you from discussing this case with us today, but it's a great episode. All right, would anyone else like to discuss? I know someone who would love to discuss and is deferring to others to see, but ideally someone identifying as a woman to discuss with Mario. Going once, going twice, Maria. Fantastic. Happy to have you, Maria and Mario. Kirtan, do you think you'll be able to bounce between scribing and teaching points? I think, yeah, I think sounds good. Okay, Doug, give us the chief concern, chief complaint in as few words as possible, and we'll get moving. And I will beg forgiveness in advance for going to 10:08 since nobody wanted to volunteer.
Great. I would like to give the chief complaint as it came to me as a consultant, if that's okay. And the consult question was brain mass.
Consult question was brain mass?
Mass.
Question mark or period. All right, so Doug has gotten a page saying brain mass. Maria, what comes to mind when you hear brain mass?
That is really interesting because we don't have any symptoms here. So I'm not like even sure, is it accidental finding or the patient came in seizing? So very variable presentation. But the thing is there's something there that shouldn't be there. And that on itself, I think deserves a consult. So I'd first be interesting in, like the age group and, who the person is, and that will help us narrow it down, like if it's tumors, what type of tumors can they be? And then probably I'll be thinking, risk factors for this patient to, brain mass doesn't have to equate tumors. They can be things like abscess or lesions. So thinking about risk factors for certain infections. So if they're coming from my side of the world, first thing on my mind would be neurocysticercosis, which doesn't have to happen in immunosuppressed patients, but definitely if the patient is immunosuppressed, that would also be interesting in terms of the types of tumors and infections they can have. And then I think the CT or like the MRI characteristics are also very meaningful, which that's not my comfort zone at all, but something very simple as being, intraparenchymatose or like extraaxial can help us narrow down the differential. And then things like ring enhancing or like where they are at, they are also very helpful. So for now, I have no idea. I'm going to ask 1,000 questions.
Fantastic discussion, Maria. Doug has presented us with a modern reality, right? We like to run this conference, and almost probably all case-based teaching conferences in medicine go from the order of how the patient presented and then their history and their exam. But the reality in real life is sometimes patients are referred to a specialist for a finding on a study, right? And the question will be, is that finding actually relevant to the clinical presentation? Many of you have heard me say this before. Sometimes you're teaching students localization, neuroanatomy, and they say, why do we still do this? Can't you just get an MRI? I always say, well, you have to know what to get an MRI of, right? First of all, based on the patient's presentation. I've probably told this story a million times, but a patient who I saw that was discharged from the emergency room countless times for bilateral leg weakness and was told it was psychogenic, kept getting a lumbar MRI that was normal, go to rehab, go to physical therapy, finally was examined by a neurologist, had bilateral upgoing toes, hyperreflexia, teaching point, the spinal cord ends at L1, got a thoracic MRI and had a lymphoma encircling the spinal cord. So you need to know what to image, and then you need to know how to interpret it, right? So this patient may have a lesion on the imaging that explains a clinical presentation or has nothing to do with it, right? And so Maria has, so this is a reality, right? That we often as clinicians get a study or see the study before we see the patient, or so that can bias us. And so we need to know what biases we have walking in. So Maria gave us a phenomenal differential diagnosis for a brain mass. We could think about a tumor. We could think about an infectious lesion. That could be an abscess. That could be in an endemic region or a region where people from endemic areas have immigrated. Neurocysticercosis in an immunocompromised patient, the differential diagnosis for one or more brain masses expands to a number of other types of infections. Maria made the point that neurocysticercosis one does not have to be immunosuppressed. And in fact, there's an old, not that old, but an old paper suggesting that maybe patients who are immunosuppressed have less problems from neurocysticercosis because a lot of the symptoms are from inflammation around the lesions. So that never proven, but a question that's come up and been discussed in the literature. And then you mentioned, so infections, tumors, and then what age group this is. Maria, how is the age group going to influence your thinking here?
Well, I always get these step 1 questions wrong because there are like tons and tons of tumors. But going from like the broader spectrum of like pediatric being infratentorial and adults being supratentorial, and then I really don't remember like any age group or any sort of major buzzword for any of the tumors, which is something I have to study. So hopefully, well, not hopefully, but maybe I get to review some of those things today.
Yeah, great. So that's a great, the point you made is for primary brain tumors, right? Meaning tumors arising from neural tissue, that in adults, they tend to be more commonly supratentorial tumors of the glial lineage, and in pediatrics, in children, they tend to be more infratentorial medulloblastoma and those types of things. But in adults, Maria, do you know what would be just the most common type of tumor you would see up in the brain or the spine?
Yeah, Mets. I think lung, breast, kidney, and melanoma, which is something I've never seen like a case of melanoma, but it's always up there. So I am not sure about how common that is as well.
Yeah, so that's right. Big point is that in adults, the most common single, people think metastases, won't you see multiple? The most common oncologic brain lesion you would see would be metastases from a systemic cancer, just statistically much more common than a primary brain tumor. And yeah, melanoma, mets to the brain, we do see sadly commonly. Someone might have a melanoma on their back and never see it or notice it, and by the time it's discovered as brain metastases. So that's a great discussion. And knowing Doug and his enjoyment of cases and Sherlock Holmes and other cleverness, this brain test may have nothing to do with this case, but it was fun still to think of a differential. So before we move on, Mario, anything else we should be thinking about here as you hear this brain mass? We've talked about tumors, we've talked about various types of infections, in particular patients, whether they are immunocompromised or not. Anything else on your mind here before we hear more history?
Not really. I just also think about brain masses. I have an etiology DDX and a neuroradiological DDX. Etiology is in infection, malignancy, and autoimmune diseases. Autoimmune, I think the only thing comes to mind is MS. There's a subtype of MS that can present with a brain mass. And a neuroradiological DDX, I would first try to categorize it between intra and extra-axial, and would search for, I think Maria also mentioned that, try to search for certain signs on the MRI that can point us towards one or the other. I think it's not that easy to point out when it's intra or extra-axial, but I think that's the first pivot point. And nothing else to add really.
Yeah, fantastic. So I'm glad I wanted to get that other category on the table here. So we have tumors, we have infections, and you mentioned multiple sclerosis. You might say, but I've seen so many pictures of multiple sclerosis, just small ovoid lesions. There are rare variants of MS where the patient presents with a mass-like lesion. It's called tumefactive multiple sclerosis. I can never recall, or I'm not sure if it's clear, maybe Doug knows whether Balo's concentric sclerosis and some of these other variants of acute fulminant demyelination are all tumefactive demyelination, or I think on pathology can have varying actual sort of histopathology. But you can rarely get a tumefactive multiple sclerosis lesion of various types, and so that's something to consider. And then every once in a while, the imaging characteristics will fool you, and you're seeing a stroke that's being called a brain mass. So if a patient has a sudden onset syndrome, right, you would say that sounds like a stroke, and then you would look at the acute imaging, and that's usually pretty clear that the patient's had a stroke. But sometimes the patient has a small stroke, or the deficits are such that they're not that apparent early on, and the time course is not that clear. And actually a subacute stroke, if you image weeks, I would say it's probably about weeks to months afterwards, there is some enhancement you can see of an ischemic stroke, which you would not see acutely, and it can sometimes be ring enhancing. I had a very memorable patient who was an elevator repair operator, so mostly by himself, not talking. At some point, he developed, you can see where this is going because I gave the punchline away, but at some point developed difficulty speaking. And this was thought to have emerged over weeks because he doesn't talk that much at work or at all. And the people who noticed him said, your talking sounds a little bit funny. It was pretty subtle and he didn't really know when it started. And he was imaged and he had two little enhancing lesions. So he got a PET scan and he had something light up in his hip and they biopsied his hip and it was just arthritis. It was one of the first patients I saw as an attending. And I looked at the imaging and I said, that looks like a subacute stroke because the area of the brain was not edematous and expanded. It was actually a little bit atrophic and there was this little enhancing lesion. I ran to neuroradiology. I said, this is a subacute stroke, right? And the guy had a thrombus just sitting in his carotid that had been there probably for some time and had acute onset aphasia at a time when he was not speaking for an entire day. So didn't notice it. So stroke is there. And in extreme cases, I have heard of cases where a neurosurgeon removes a brain tumor and the pathologists say you removed an ischemic infarct. So this can be ambiguous in the subacute setting. So I put that on the table as well. And then you mentioned, Mario, if we're in the tumor field, right, in the spine, people talk about extradural, intradural, extramedullary, and then intradural, intramedullary. I don't know why people only talk about that for the spine, because I think it's a reasonable classification for the brain as well, or intraaxial, extraaxial. Is it in the brain parenchyma itself, or is it in the meninges bone resting on the brain? So that's a great discussion of what might have been running through Doug's mind as he said brain mass, question mark. I'm curious what that is going to look like and what, if anything, it might have to do with this patient's presentation. So what happened next, Doug?
I'll just say that fantastic discussion. The reason I wanted to come in with brain mass is because I think it was the time and the clinical reasoning duration in which this patient was not labeled as brain mass was about 5 minutes in the outside emergency room. So I said, why should we spend all our time in there? Because as you all just brilliantly demonstrated, there's so much you can do with 2 words, even if it starts with an imaging finding, as it often does, as Aaron mentioned. And there's still so many question marks. So the backstory, a little bit of the backstory on this patient is that it's a 59-year-old right-handed man who was found walking in the street confused and reportedly, per the EMS folks, had slurred speech, unsteady gait, maybe a facial droop, was altered and combative, and was put into an ambulance and brought to a hospital, and en route in the ambulance had what was called a generalized tonic-clonic seizure. Came into the emergency room, was more confused and lethargic at that point. The basic initial kind of info that came in was that he had normal vital signs, was afebrile, had a normal CBC, BMP, LFTs, UA, and I'll stop there on the initial studies to see what else you guys might want. But it occurs to me that at some point I'll want to show you this lesion, but maybe a little bit more about the background first. Is that all right? Because we did get some early information from the family. The past medical history for this patient is extensive alcohol use disorder. He also has had chronic swelling in his legs, and has also been treated for a chronic right foot skin ulcer that was complicated by a bad cellulitis about 2 years ago. The patient is from California, lives with a partner in a trailer, and has traveled kind of throughout the Pacific Northwest, has traveled a little bit in kind of the central northern part of the country, Colorado, Utah. Nothing really recent, but within the last 5 years or so. Family wasn't aware of any drug use. Hasn't been around any sick contacts recently. The family mentioned that they're not in great touch with this patient, and that they have seen him like within the last few weeks, and he's been intoxicated a few of those times, so has been acting kind of altered, and so all they could really tell us is that he's been actively drinking alcohol, as far as they knew. So there's not a ton of information about when this person was last known kind of normal at their mental status baseline, because he's not socially very well connected with some of the people we could get information from. And then, there was, and we'll stop there.
Oh, no, go ahead. Go ahead.
Oh, let's see. From the family, there was no known family history of neurologic disease. And yeah, we didn't get much more interest. The further history we could get kind of, was limited at that time. But when they came in, that's pretty much what we knew.
Perfect. No, I was just giving you a thumbs up because I was enjoying the case history, not to stop you.
Oh, sure.
Great. Mario, you're up first this time. What's running through your mind with this information that we have now? Obviously, we're all biased a little bit by what does this have to do with brain mass. So you can choose to incorporate that finding, or you can choose to just talk about what's running through your mind when you hear this history, whether or not you had known there was a brain mass. Either way would be interesting.
Yeah, actually, the HPI, I just attributed it completely to a brain mass. Maybe that's a mistake. But
Mistakes. Yeah.
What really took my attention is the past medical history and the social history. I don't associate alcohol with a certain brain mass, but I think there can be certain associations. Does this patient also have IV drug use? Is this patient also this patient at risk for endocarditis with a mycotic abscess, or a mycotic aneurysm or a brain abscess? I think that's in the infectious bucket would be something to keep in mind. Is the patient immunocompromised and at risk of all the infections? Immunocompetent patient is at risk also, but also the added risk infections like toxo. I think mainly toxo if I'm thinking brain mass and immunocompromised patients, and in the malignancy bucket, lymphoma. And the patient also has a fairly significant travel history. I think almost all endemic mycosis can cause brain granulomas. So I think that's also something to keep in mind. And that's what I was thinking.
Yeah, great thoughts, right? I think there's so many different frames here, right? What is the problem representation, right? If you said a 59-year-old patient with what sounds like relatively acute, so for now we'll say acute change in mental status and possible focal deficits and a history of alcohol use disorder, as you said, how would I incorporate a brain mass? You wouldn't have thought of a brain mass. Maybe you think of a subdural, or you think of alcohol withdrawal with Wernicke's encephalopathy, right? Or what if you said this is a 59-year-old with acute confusion and a history of potential exposures in California and the Pacific Northwest? As you said, you're thinking of endemic mycoses. And then what if you said a 59-year-old man with a history of confusion, slurred speech, et cetera, and a new brain mass, right? You're thinking, well, the brain mass must be doing something. So, as Doug said, and as I was saying earlier, right, a lot of this case is going to hinge on what that thing is, right? And although we walk through these cases saying, well, let's first get the history, first get the exam, there's obviously a lot to learn by doing that. And in some locations in the world, right, there would be no imaging, and that's all you would have. But an important part of the modern clinical reasoning, right, is incorporating all of this data we get and trying to make it make sense, or find a way that it could make sense with the history and exam. And as some of you have heard me say, in a complex case, when there's all these different pieces, sometimes everything all points, all the Venn diagram circles overlap, and it's the thing in the middle. And sometimes you just have to take one ingredient out and say, where does this congeal? So I agree with you. Alcohol use disorder wouldn't make you think of a mass. But as you said, if someone is abusing alcohol, could they also be abusing drugs, right? And could those drugs lead to endocarditis or immunocompromise, leading to some type of opportunistic infection? That's possible. Or as we know, a lot of patients are sometimes seen and they have a history of alcohol or drug use, and their history and their presentation is attributed to that. And in fact, there's something completely different going on. I saw a patient a very astute medicine resident noticed some asymmetry to the ataxia in a patient who was intoxicated with alcohol, had a history of alcohol use, and ended up diagnosing a massive cerebellar stroke buried in a confusing clinical presentation of severe alcohol intoxication. So we don't want to stop there and say this is this, and we have to obviously be very diligent. The endemic mycosis, so for California would be cocci, I guess, right? I'm still new to California and learning my endemic mycosis, but Maria is shaking her head and she's studying for step 1, so I trust her. My understanding is cocci, blasto, histo, obviously in different locations, they can cause brain mass, they can cause early spine mass, they can cause meningitis, but most commonly patients will also have pulmonary disease, is my understanding. I've never seen a case of these, so Doug might have to enlighten us since he's been training in California and probably seen a handful of these or maybe more. They can have isolated meningitis, they can have isolated brain lesions, but either meningitis plus brain lesions or one or both of those plus pulmonary disease, which we didn't hear about here. So I'm not sure anything in that lower left-hand corner is necessarily going to be the key in this case. So one thing that might be interesting is to just take the history and try, if we can, to ignore brain mass and the other stuff and ask, what would you just do with this history? Do you want to take a try with that, Maria? If we just had this HPI, if Doug had given us the chief complaint is confusion, and this was the history, this confusion, altered gait, facial droop, seizure, sure, we can keep the alcohol use disorder in the Pacific Northwest. What did I forget to mention? Pacific Northwest, there's Cryptococcus gattii, not neoformans, which is a cryptococcal species that can affect immunocompetent patients that lives in the Pacific Northwest. I've never seen a case, but something I learned recently. Okay, so what would you do with just that HPI, Maria?
Yeah, and I think
with or without brain mass, up to you.
No, I think it's very important to take out the brain mass because, for example, a lot of the mnemonics we use for altered mental status or like whatever schema you want to use for altered mental status, it's not either, you don't have to like pick one category and go with it. It can be like and or everything. So when you have altered mental status, you can have something structural, like in this case, but then you can also have something infectious, something metabolic, or something toxic, especially with this patient who has an underlying alcohol use disorder, because that can explain a lot of their symptoms. So for example, the confused slurred speech, the altered gait, even like causing hyponatremia and causing a generalized tonic-clonic seizure, and and then the brain mass can be something accidental. And maybe when Doug shows us the imaging, it's just like a non-important meningioma, and the patient is having hyponatremia or something like that. So I think it's very important to always, Robbie has this, he calls it the law of proportionality, and it's just how does the findings actually explain the symptoms. And so, for example, if we have like a very important brain mass that's taking a lot of brain parenchyma space, that, you know, it's proportional to the symptoms. But if we have like a very non-consequential mass, then we have to look for something else. And so I think what I do, especially because this patient, it seems the history has been taking for quite a while, I wouldn't be thinking vascular right at the top of my mind, because that would be more sudden. The alcohol use disorder would lead me to thinking something more metabolic or toxic. And with the infectious, I think I don't know how often brain abscesses present with anything else. So I'd be looking for something in the heart, lungs, even if we're thinking about like endemic mycosis, looking for something in the skin, or if not in the physical exam, looking for something in the labs. But those all seem normal for now. So very interesting. Again, I'm not quite sure. I'm just opening up more the diagnosis instead of narrowing it down. But I think it's all gonna come down to like checking the physical exam and then looking at the imaging Doug has for us.
Yeah, fantastic discussion. I had not heard Robbie's law of proportionality, but the mathematician strikes again. I love that, right? I have that much less sophisticated, non-mathematical way of thinking about it. Sometimes you have to take something out, right? It's my way of thinking and see what the other two things or other three things hang together. I guess where I'm thinking here is if you told me just this is a case of a 59-year-old man with, or woman, 59-year-old person with altered mental status and a generalized tonic-clonic seizure, that's all seems relatively acute. We always say localization plus time course. There's no mystery to the localization here, right? We're in the brain, right? But what would you think of that time course if you just said this is someone who was at least in their relatively normal state, although clouded by intoxication a few days ago, and is now not in that state and is confused and having a seizure? Maria or Mario, what sort of diagnoses might come to mind? Or etiologic categories, taking the brain mass out, everything else for now.
I think this would fall on the acute symptomatic epilepsy or epileptic seizures. And I think we have to look for, could be, I think almost all categories fill in. It can be a metabolic problem, can be structural, either an infection, malignancy, toxic / metabolic, I think we mentioned that, and vascular, I think also is something to keep in mind.
Yeah, fantastic. So I would be thinking about toxic, metabolic always, right? What is this patient's sodium, calcium, magnesium, glucose? We heard those were normal, both for the confusion and the seizure. I would be thinking about an encephalitis, right? Does this patient have herpes encephalitis, one of the most common viral encephalitides, and is the temporal lobe swelling of that being called a mass? That could be a possibility, right? Does this patient have meningitis and is developing this confusion, and again, alcohol and other things, unless maybe poor dentition or something, we can't relate everything together. And then I have to say, from the first words, 59-year-old man found confused, something jumped into my mind here. And another possibility I should say before I say that, Mario, is that this patient had a stroke, right? He lives alone. He is drinking, and his mental state is maybe not entirely clear to be self-observant of what is happening. We don't want to pass that judgment, but it sounds like he's spending most of his time intoxicated. Maybe somewhere in there he had a stroke, right? And you might say, well, is there fake focality here? Well, we're going to find out on the exam. But there are a series of strokes, usually when neurologists are consulted for altered mental status, as Doug can concur. Almost always it's some medical issue or multiple medical issues, right? The fact that it's the time, what should I say, the proportion of times in which it's a primary neurologic etiology causing delirium and acute confusional state is a pretty low percentage. But what could you think of? Meningitis, encephalitis, right, is on the differential diagnosis. Did this patient have prior seizures and the altered mental status is just a postictal state, or the altered mental status is ongoing non-convulsive seizure activity? And then there are a series of strokes that can cause confusion, a series of locations in which stroke can cause confusion without really much focality. So for whatever reason, the right MCA inferior division, so superior division, you'll get your left hemiparesis, your neglect, all that stuff, but inferior division, the sort of right temporal parietal, these patients can be very confused. I had a case in the emergency room as a resident. The ED doctor showed me the scan. This patient has a right MCA stroke, please admit to neurology. And even knowing that, and he came because his wife said he was driving on the wrong side of the road and all of these things that showed he was acutely confused. I couldn't find anything tangible on the exam. No neglect, no field cut, no pronator drift. He was clearly confused, but I found nothing sort of obviously focal. So right MCA, stroke of the thalamus, neurologists love to say thalamus can do anything. A stroke in the thalamus, patients can be acutely amnestic, they can be confused. You can get the ACA without getting the motor strip, and then you get just sort of frontal lobe kind of confusion, and then diffuse small emboli, as you can see after a cardiac surgical procedure, catheterization, where the patient has a starry night MRI. I call it a starry night MRI, just countless tiny little dots of stroke, and there's nothing focal, but they've disrupted enough white matter pathways that they're confused. So a stroke is in there. But what was I going to say? Hearing this age group and man and acute confusional state and seizure made me think of a particular diagnosis that may be right or wrong. One of my mentors, Marty Samuels, who some of you have seen do these conferences every whatever Tuesday of whatever month or Wednesday, extraordinary master clinician who used to run, I think still does run Morning Report at Brigham and Women's, where I trained almost every day. He talks about this book by Kahneman, the economist, called Thinking Fast and Slow, that there are these two thinking systems, right? That you hear something and you make a kind of snap judgment, and that has some validity, but you have to have some mistrust. And then there's the sort of slower thinking where you kind of gradually put all the pieces together. The thinking fast for me on this was an obscure diagnosis called cerebral amyloid angiopathy related inflammation. Now, most people have heard of cerebral amyloid angiopathy. It's the same amyloid as in Alzheimer's, but it's in the vessels. And so these patients are prone to intracerebral hemorrhage. It can coexist with Alzheimer's disease, or it can occur independently, very common cause of hemorrhage in older patients. However, there's a rare variant where the immune system does not like the amyloid in the blood vessels and attacks it, and the patient develops what's called CAA-related inflammation, or CAA-RI. And these patients present just like this, as an inflammatory syndrome, so pretty acutely, with progressive confusion over days, weeks, usually culminating in a seizure. And what they have on imaging is areas of microhemorrhage as an amyloid, but areas of asymmetric T2 hyperintensity inflammation. This just reminds me very much of a case of a guy who was combative and also had, I think, problems with alcohol, ended up in jail for all his combativeness, was released from jail on bail, and then had a seizure, came to the hospital and had 1 million microhemorrhages and this asymmetric T2 flare hyperintensity. He tried to escape from the hospital. People were chasing him around. We figured this out because we had one of the people who described this in our hospital. We gave him 1 dose of steroids, and the next day, I'll never forget, he was watching the baseball game when we went into the room. So it's a very treatable disease. Anyway, that jumped into my mind in the thinking fast realm, and whether, again, that idea of brain mass actually was it not a mass. But as Maria said, there could be a 2 millimeter meningioma or pineal cyst or something that has nothing to do with it. So because of all these things on our differential, right, we obviously want to see that picture, and Doug might have seen it before he even saw the patient. That's not cheating, that's real life these days. That sometimes we see things in different orders, right? But we'll want to see on this exam, is there any focality? Because we want to see if there's a left hemisphere lesion and the patient has a left hemiparesis. Yes, some small percentage of patients have uncrossed corticospinal tracts, but we would have it would be hard for us to prove and invoke that, and we would probably say that's not related to this. We need to think about this in a different way. Okay. So I leave it to you, Doug. You may have seen the imaging before the patient, and if you think it's interesting to show us things as you saw them in real time, or if you want to give us the exam in the traditional way we do things, I defer to you and how you want to present the case.
I think I'll tell you the exam first. And I'll just make my one quick comment is that I just wanted to commend Kirtan and Maria for resisting the chief complaint, resisting the mass, because that can be extremely difficult and very enticing, and it shows an immense, like a very high level of maturity, I think, to step back and say, this could just be a meningioma, and people, the teams get really nervous about the imaging, so that's kind of the front billing. But a big part of being a good consultant is not only helping teams, figure out what the core consult question for a neurology service would be, but making them feel like, really developing a good kind of inter-team rapport and making you feel like you're on the same page, and not like, not implying, oh, you were wrong to ask it this way, or, but really kind of sort of building a good clinical reasoning team between the teams. So great job with that. I think that was awesome. Let me tell you about his exam. I'll say, it was mentioned that altered mental status could be due to postictal state. I'll say that this exam was about 5 days after he had his witness seizure. He was on EEG in the room when I went in there, so I was able to look at the tracing, and he was not having seizures. So he was alert and awake. He was, or let me tell you, his general exam, very poor dentition. He had a lot of kind of soil, dirt on his under his nails and on his hands. He had some mild pedal edema, a small ulcer on his left foot that was dry and didn't have any fluctuance to it. He had some small abrasions on his arms and forehead. There was no notable skin findings aside from what I mentioned. His mental status, he was alert and awake. He was regarding and tracking. He could follow one-step commands, midline commands, close your eyes, stick out your tongue. He could not accurately follow any appendicular commands or anything complex or multi-step. He could name very simple objects, very simple objects. He could not repeat, and he was extremely perseverative. So if I asked him to say the word thumb, he could say thumb, but then he would say thumb pretty much throughout the rest of the exam for almost every command. He was, there was no gross neglect. He was, attending well on both sides of the room when, I walked around the bed. Cranial nerves were grossly intact. There was no asymmetry that I could note. And his motor exam, same. He was briskly anti-gravity in all of his limbs. He was paratonic throughout, had a lot of trouble kind of complying with relaxation. Sensory exam was also non-focal, and he was grossly non-ataxic, meaning he could reach for my hand, he could reach for my reflex hammer without any gross ataxia. And I just share that exam because, as you see, sort of like Aaron said, not much after the mental status.
Yes, fantastic. And the reflexes were nothing to write home about.
The reflexes were nothing to write home about, but granted, difficult because difficult to get them to stay still, but nothing, I think those were equivocal. I could say there was no Hoffman sign, and otherwise, nothing.
Got it. Okay. Yeah. Sometimes it can, many times it can be hard to get the right positioning and everything for reflexes in a patient who's acutely confused. But that can be subtle clues, right, to asymmetries that could hint at focality if we're having trouble. Obviously, in this patient, you're not probably going to be able to see that one side was 5 out of 5 weakness and the other side was 4 minus or 4 plus, right? So Doug is saying, right, you're looking at this patient, seeing they're moving everything semi-purposefully. There's no obvious gross asymmetries to suggest a focal lesion. So Maria, I think you're up. This is not a, what's your interpretation of the exam? Then I had a kind of guess what I'm thinking question, but I will let you go first before you guess.
Yes, I feel the same way as Doug. I don't see anything that really pulls me towards like something defining. Good to know that he has like an EEG, so we can rule out seizures and postictal state. And I think with EEG, you can also see signs of like encephalitis and things like that. But if it's normal, yeah, we can rule that out. I think in this case where a lot of it is gravitating towards the mental status, it's very hard to figure out, is this something new? Is it like a consequence of the seizure, or is the patient been like this for a while now? I think we have some clues that he might have had like poor mental status for a couple of weeks with his hygiene. That's something that we tend to see with dementias and delirium. People really don't take a lot of care for themselves. And with the small ulcer that has healed, that shows this has been going on for a while, but that is just trying to look for something because we don't have a baseline for this patient. And I think that I can't think of anything else. Yeah, with the presentation, it might be something like an infectious site, but a lot of people have presentations and they don't have any infections, so it might be nothing.
Yeah, I think that's a great summary, right? We love the exam in neurology, and we've certainly had last week, right? We were able to, with the exam, make a very precise localization and diagnosis by looking at the eye movements, right? And sometimes we sort of go into the exam saying, well, we've heard about a patient who's confused with an interesting context and a potential imaging finding. And what did we find? The patient is confused, right? But we see that there's no focality. As I mentioned, so confusion, we could call this an encephalopathy, right? It's sort of like brainopathy, right? It's not a very specific term, and that could be from a diffuse process, a multifocal process, or very rarely, as I mentioned earlier, what we would call sort of a strategic lesion. So when people talk about vascular dementia, right, on step one, it's always stepwise, right? They had one stroke, they got a little worse. In real life, it's often just sort of progressive. as patients accumulate subcortical white matter disease. But there's also a type of vascular dementia that's called due to strategic infarct, that someone had a small infarct in the thalamus or a small infarct in the hippocampus, and they developed sort of a acute, essentially, dementia, or they kind of accumulated these lesions, which is not always stepwise, but for step one, stepwise, that will get you that right answer until we either get rid of step one or neurologists are allowed to write the questions. Okay. So right, this patient has a brainopathy. This patient has an encephalopathy, right? And all we have to go on is the context. And I think what was already done is what all of us would want to do, is take a picture of the brain. And before we see a picture of the brain, I always like to ask myself and students or residents that might be rotating with me or working with me, what do you think you're going to see on this? Because I find if you ask yourself that before you see the imaging, either the confirmation tells you are on the right track, or the surprise has a little more emotional valence to what you learned from misjudging. Not misjudging, making a judgment based on the facts that you had right and having it be not correlating with the imaging. So, and here we have the even more complicating factor of that those two words, brain mass, kind of looming over us. So Mario, Maria, and then I'll say, what do you think we're going to see on this imaging? Even you can just say, are we going to see something or nothing, right?
Can I add something from the last aliquot? I think in terms of the ulcer, I think it's probably a venous ulcer from the pseudoedema and varicose veins. But something I've actually seen in Peru is sometimes, especially if a patient report a history of trauma and they have a long-standing ulcer or a cutaneous lesion, they can be inoculated with a free-living amoeba, and they can progress in a couple of months to amoebic granulomatous encephalitis. And usually the ulcers are non-healing and more like plaques than ulcers, but that's something that came to my mind, just something to add. Usually balamuthia I think can affect immunocompetent patients, and acanthamoeba usually only in immunosuppressed. Just wanted to add that in there.
Yeah, that's a great thought. I was thinking that we hadn't really talked about the skin lesion or the leg swelling, and we sort of left them out. The three of us are sort of going that way, but you're right. These are uncommon. Balamuthia, they have these amazing names, acanthamoeba, amoebic granulomatous, amoebic encephalitis, is that it? GAE is one, and it's called an encephalitis, but I believe the imaging actually shows multifocal findings. And you can be immunocompetent and get those. I forget, someone in ID can tell me how are they from fresh water? Are these the ones people got from the neti pot cases? I see Robbie there. Robbie will know. Robbie knows the answers to all things. But yeah, skin lesion, an encephalopathy, those would be super rare. I've never seen a case. Is that right, Robbie? Fresh water for those two?
It's funny. I get a little jittery speaking on Neuro VMR.
I get a little jittery when I see you in Neuro VMR. So it's a mutual jittery admiration society.
I'm taking down notes of all the wisdom you're sharing, and what I will add is that I think they're both soil-dwelling organisms, so they're found in the soil, and acanthamoeba just happens to get into the neti pot, but really it's from organic material in the world. But yes, so acanthamoeba is the one that's associated with neti pots, and the one that unfortunately causes devastating local disease in the eye and contact lens wearers.
Wow. Yeah. And there's this, okay, anyway, so you can get amoebic and granulomatous. I'm sure Robbie could give us a 1 hour spontaneous presentation with drawings of the bugs themselves and their genetics. But thank you for reminding me how those. So yeah, this patient has dirt under his fingernails, right? Is that a clue Doug is giving us here of the dirt exposure if we want to go down the ID rabbit hole? But I think Hart says, you're wondering, are we going to see multifocal lesions consistent with granulomatous amoebic encephalitis? Interesting thought. Maria, what are you thinking we might or might not see here? Yeah, I don't know either, so.
Yeah, I'm not sure, but I think I'm going to go with abscess or No, let's go with abscess. I'm going to go with abscess and not the broader infectious category.
So a bacterial abscess just sitting somewhere in the frontal lobe or something where it's far enough forward or we're not seeing anything focal, but enough to confuse the patient. Well, I'm glad you two went first. I really don't know, and I don't know what to do with that. I don't think it will be normal, which is important to say, right? A lot of patients who are confused will have normal imaging, and we know we have to look somewhere else, labs or cerebrospinal fluid. Going back to first principles, right? If we just make a problem representation, this patient has what we think is an acute encephalopathy, right? So if that's what we're dealing with here, we have toxic metabolic etiologies and we have infections and inflammatory pathology as the sort of main categories here. We have a set of electrolytes. We heard about labs earlier. We don't have a tox screen. That's sort of possible. Wernicke's encephalopathy, something we could invoke from the alcohol, right? You say, oh, Doug said the cranial nerves were normal, the eye movements were okay. Why is there no nystagmus, no gaze palsy? This triad of confusion, ataxia, and eye movement problems in Wernicke's encephalopathy, I forget what the number is, but some pitifully low percentage have the full triad, right? So you could just have encephalopathy and have Wernicke's encephalopathy. So that's still on the table here if we're tying the alcohol piece here. And then what to do with that brain mass thing, right? Does this patient have herpes encephalitis? Everything else is noise, and the mass is the swollen temporal lobe. Does this patient have the condition I mentioned, which this is the problem with thinking fast and anchoring bias. Once I got it into my head, it's hard to take it out. This patient just reminds me the way Doug is describing so much of the one patient I saw with this super rare condition, cerebral amyloid, angiopathy-related inflammation. So I suspect we are either going to see a focal lesion in the frontal lobe or maybe inferior temporal, inferior parietal, where we're not going to, parieto-temporal, we're not really going to see anything focal on exam, or nothing obvious enough that we could get in a confused patient without a detailed exam, or multifocal small things. But what they are, if the labs are all normal and the tox is normal, I think we're in the infectious inflammatory category still here. And if the scan doesn't tell us what it is and there's not too much intracranial pressure to, or signs that the patient looks at risk for herniation, probably would need some spinal fluid. So that's sort of where I am with it. I don't know, and that's a fun place to be 5 minutes before the end of the hour. What happened next, Doug?
Maybe I can, since we're towards the end of the hour, I can give you a couple, a good dose of info. I can maybe show the imaging and then talk about some spinal fluid. Does that sound okay? Okay, so I'm sharing my screen now. So this is his initial image, and I'll show you some different, this is the diffusion weighted imaging. And I don't know if somebody else wants to point out some things, or I can point out some things.
Mario or Marisa, if you can tell us, if you know, if you don't, that's fine, what the significance is of diffusion weighted imaging and anything that you might see here.
I don't like imaging, so Mario, you go.
I'm usually, what I guess in diffusion weighted imaging, I think about it in terms of looking for when we're on a stroke code to look for the penumbra area. So, but I'm not sure what the physics of the diffusion weighted imaging is, but what I see here is a little bit of a hyper intensity on the left-sided imaging. I'm not sure which structure that is, but I'm really not. I don't think I could really give it a good analysis of this image.
No problem. So diffusion weighted imaging, as it sounds, I don't understand the physics of MRI at a physicist level, but this is looking somehow through magnets at the ability of water molecules to diffuse through tissue, right? So where there's tissue is denser, water molecules have more difficulty diffusing. So you already see the cortex is a little brighter because that's a lot of cells, cell bodies packed together, and the white matter is a little darker because myelin is less dense. There's room for water molecules to diffuse. That's my crude understanding. So you're right. The most common use of this is to look for acute infarction because when you have cytotoxic edema, those swollen cells, then you have difficulty of water molecules to diffuse through them. And this can show infarction within, well, we don't know minutes because no one comes to the hospital within minutes, but certainly within probably about an hour. However, there are other things that cause difficulty of water molecules to diffuse through them. Very dense lesions like an abscess, or lymphoma. Think of the pathology, lots of little blue cells. And I'm not sure the pathophysiology of why Creutzfeldt-Jakob disease, the cortex is diffusion restricting, presumably lots of swollen cell bodies with prions in them. I don't know. But yes, so this is bright on diffusion restriction. I'm going to presume Doug would tell us that the ADC is dark. This is true diffusion restriction because you can get a phenomenon called shine through, where T2 flare hyperintensity just shows up on here, but it's not truly restricting. And that's limited to what looks like the left inferior medial temporal lobe in that left image, and the left posterior inferior thalamus in that right image. So those two do link up as part of the posterior cerebral artery territory. We always think visual field cut, right? But actually those, the posterior cerebral artery territory includes the thalamus and the medial temporal lobe. So that's possible, right? As I mentioned, I don't remember if I mentioned in my list of possible, I mentioned the thalamus as a place where a stroke could cause acute confusion, but a PCA stroke without the field cut, so more anterior in the PCA and not getting the occipital lobe, or the patient is so confused that trying to do your 2s, 5s, and 1s in the corners of their visual field doesn't work. So this could explain the patient's presentation. There's just a stroke in there, but I saw Doug accidentally flash forward to the FLAIR imaging that shows there's a lot more going on here.
Here we go.
Yeah. Okay, now what do we have here, my friends?
And I have contrast enhanced image and SWI after this.
Oh, well, by saying that, you've even further anchored my anchoring bias. But go ahead, Maria or Mario. If you don't know what FLAIR is, that's totally fine. Just tell me what you visually see here.
I think what I see is, what I'm trying to determine if this is intraaxial or extraaxial. I believe this is intraaxial, an intraaxial process. I see I think it's a very apparent hyperintensity. I'm not sure if that's a primary lesion or a reaction, like a type of vasogenic edema, and the lesion is somewhere else, because there's a focal lesion on the posterior left occipital. I think that's the occipital lobe, or the posterior aspect of, at least, of this image. Well,
Yeah.
I'm not sure what's the primary, or it's all the same lesion.
Yeah, great. So this is in a distinct location, different from what we saw in the previous images. FLAIR is fluid attenuated inversion recovery. This is a T2 image. So the gray matter is brighter than the white matter, but it's inverted so that the CSF is subtracted out. So on a T2, the CSF is bright. It looks like the negative image of a T1. But if you subtract that out, it helps you see a little more clearly what's bright around the ventricles. It's not relevant here because we have a big lesion not near the ventricle, and that is the anterior temporal lobe. And we see T2 hyperintensity in there. And if you look, this is more clearly seen on the left image. It goes right out to the cortex and then stops, right? So this is a juxtacortical or subcortical lesion. At one point, we had mentioned herpes encephalitis. And if you're taking step 1 and you see big, bright temporal lobes in the right clinical context, it's HSV. But in my experience, HSV, what you see is the cortex is very swollen and bright. And it's hard to see the white matter because everything's smushed together from that edema, but this does not look like herpes to me. Okay, next. I still don't know what this is. All right, so now we see a T1 pre-contrast on the left, and we see that region that was bright is dark, that edematous region. And on the right, post-contrast, what do you all see in there?
Like an epicenter, right? It has an epicenter with, I think, some contrast enhancement, but I wouldn't call that too significant.
Yeah, there's definitely some contrast enhancement there. It's not a ring enhancing, at least as far as we can see. Obviously, it's always hard without scrolling up and down. Doug can tell us. It looks like there is some central lesion, right, with edema around it, and the enhancement pattern looks irregular, which continues to be non-specific. It's always important to look at the pre and post together, because blood on CT is always bright, right? But on MRI, depending on whether it's T1, T2, and whether it's hyperacute, acute, late acute, subacute, chronic, there's this IB, itty bitty, BBDD, or I bleed, die, whatever the mnemonic is that people try to remember. Blood can be bright at a certain stage and you can get fooled. You pull up the T1 post, say, oh, it's an enhancing lesion. You always have to look at the pre. So I still don't know what that is. Okay. Was it ring enhancing on other images, Doug, or?
No, this was, like you mentioned, it was a central lesion that had some kind of sort of faint, patchy, sort of open ring enhancing areas. I'll also point out that there was asymmetric dural enhancement kind of right around the edge of this lesion, which was kind of an interesting finding as well. The next sequence, this is just a diffusion weighted, or excuse me, an iron sensitive sequence, or susceptibility weighted imaging.
So this susceptibility weighted imaging, or gradient echo imaging, or SWAN, which I don't know what it stands for, these are all images looking for darkness, and darkness is either blood or calcium, and we see near where it looks like it was enhancing some specks in there that could be calcification or microhemorrhage. Is that all you have for the imaging, Doug?
I'm gonna, because where we are in time, I'm gonna give you another time point 2 weeks later. Is that okay?
Sure.
This is just, I only have a flare sequence for you.
All right. Note to self: when Doug is presenting a case, leave a lot of time for the imaging and final outcome. That's my fault.
No, it's mine. My intention was to show you the imaging early. That's why I started with brain mass, but you all ran with it in such a brilliant fashion. I couldn't.
Nothing to apologize for. I'm just, my time management, as people know in these, is I get too excited at every stage. So what's interesting to me here, just in the interest of time, is that the extent of the lesion appears to have progressed, but it doesn't really appear to be edematous, right? So if you look at that left temporal lobe, there's more extensiveness of that change in the white matter, but it's not closing off the ventricle, right? The temporal lobe doesn't really look that much bigger than the one on the other side. So this thing is evolving, but not causing mass effect or increasing mass effect. And the fact that it goes so medially, I don't know if you have contrast from this time point, Doug, but sarcoid loves that kind of dural and kind of hypothalamic region, but this would be a sort of very odd, very acute presentation for neurosarcoid, which can do anything, most commonly just the seventh nerve palsy, but can cause sort of a mass lesion, can cause dural enhancement, though in my experience, leptomeningeal enhancement a little more common. I don't know what this is. Yeah, what happened next? I guess one question would be, Doug, did you and your team look at the imaging and say, we have a strong hunch of what this is? I should say, I think cerebral amyloid angiopathy related inflammation is on the table. There is some flare stuff with some blood in it, but it's not a classic appearance for that. I'm not sure you would see that enhancement. And presumably if Doug and his team thought that, they would have given him steroids and we wouldn't be watching it get worse 2 weeks later. So I guess I'd be curious what your team thought about the imaging and whether you thought you knew what it was, or often in these cases we get CSF, we still don't really know what it is, and probably this patient needs a brain biopsy to really get an answer. Although we'll try to get at it with CSF and SPECT and all these other studies first. But yeah, what happened?
Sure. So those two things happened. I'll also mention that and it was a little unfair that I didn't tell you, but between those two time points, the patient did get a course of steroids at a time when, so on the first presentation, he had an LP. The opening pressure was 17. He had 96 white blood cells that were 20% neutrophils and 80% lymphocytes. 750 RBCs. The protein was 38. Glucose was 120 with a high serum glucose. And I'll say extensive microbiological testing, including metagenomic sequencing, was all negative on this CSF. Extensive serum testing also came back negative. And the patient, someone had actually asked in the chat about an eye exam, and there was an ophthalmologic consultation, and there were no abnormalities on an eye exam, including a fluorescein angiogram. And we, like Aaron mentioned, we wanted to proceed next with tissue.
Yeah, I was going to, before you tell us what you found. Yeah, so the lumbar puncture, right? The protein is not elevated, but there's a lymphocytic pleocytosis with a normal glucosobacterial etiologies. tubercular fungal, probably unlikely, and this protein is not high. So that pattern of a fair number of whites and not that impressive response on the protein, I'm not really sure what to do with that, but there's definitely something infectious or inflammatory going on, right? And we have not found an infection. And Doug is at the epicenter of metagenomic sequencing, where you can look for any fragment of any genetic material from any infectious particle, and you're likely to come up with something, right? And that's another case where you have to figure out, is this actually relevant, right, to what we found? And if you really found nothing there, then you probably don't have an infection, right? So this is a case where, gee, if you ruled all that stuff out and it's not really looking like a tumor because there's sort of edema without mass effect, giving steroids, as Doug's team did, to say, is this amyloid-related inflammation? Is this some type of vasculitic process of which those two sort of overlap? Is this at least not an infection enough that I think it's some inflammatory thing? There are case reports of NMO presenting as a mass lesion. I guess that could be on the differential here, sarcoid. Do you say, well, let's just give steroids? Or if the patient is not unstable, you could say, you know what, if we give steroids, we're going to confuse the biopsy result. The surgeons will get a tiny sample the size of the head of a staple, and the pathologist will say there's some non-specific inflammation, but it's reduced because you guys gave steroids. And we're back where we started. I'm sure Doug has seen that scenario a number of times. So I think this is a case where we would hope for the answer on tissue, although from Doug's center, UCSF, a study several years ago where they published their results of brain biopsies for a few years in patients who present with sort of a rapidly progressive altered mental status and no clear diagnosis. I think the number one diagnosis is no diagnosis. And then lymphoma is always high on the list, which I consider our generation's great imitator in neurology. But presumably the CSF would have had flow cytometry and cytology, although sometimes you need 3 lumbar punctures to actually be definitively sure that you don't have that. And instead of subjecting the patient to that, probably you would just end up getting a biopsy. So what could we see? Could this still be amyloid angiopathy related inflammation? I think that is on the list. There's those tantalizing little hemorrhages there. Is this lymphoma, which usually will diffusion restrict? And then, hey, we forgot about those remote diffusion restricting lesions that weren't even part of the lesion. What's that about? Is this some type of vasculopathy? And so vasculopathy plus inflammation is vasculitis. I think we're in the inflammatory category here. So what's left, right? Sarcoidosis, vasculitis, cerebral amyloid related inflammation, and then a surprise lymphoma at the last moment. Or is Doug giving me another case of syphilis just to taunt me for missing the last one, saying everything was negative except the RPR? I don't think so. I don't think that's a gamma. But meningovascular syphilis with a gamma too. Fool me once, shame on, what is it? It would be shame on me twice. So I'll throw syphilis on the list just for sportsmanship with Doug having a history of stumping me very well. But I'm going to say something inflammatory in the vascular domain because we have those strokes and hemorrhages and an evolving picture without evolving mass effect. Okay, Doug, what was on that tissue?
So the brain biopsy, including a dural biopsy, showed florid granulomatous inflammation that was concerning for infection, but all the initials, well, I'll just give you that. And I'll say the next aliquot had to do with, well, the next aliquot will reveal the diagnosis.
Granulomatous involvement of the parenchyma or of the blood vessels or both?
Of the parenchyma. I don't know about the blood vessels actually. I'm sorry, but
that's fine. Yeah, I think if they were there, I think you would know. Okay, Mario and Maria, here we are. I'm only 3 minutes over since we really started at 9:08. What is going on here?
I think sarcoid is still on the table, and granulomatous infections. I think if we don't mention TB, I think it can be TB. And we talked about certain fungal infections, but it's pretty surprising that none of the infectious workup came out positive. So maybe sarcoid, neurosarcoid. That's the only thing that comes to my mind.
Yeah. So in some parts of the world, right, a new brain mass in a patient who's confused, the differential diagnosis would be tuberculosis, 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 and then all the things we discussed, right? Could this patient have gotten tuberculosis and had a tuberculoma? I believe those usually have a pretty thick ring enhancing type of picture. So yeah, what's granulomatous that's not TB? A vote for sarcoid. Maria, anything else on your differential here?
No, that's it. And maybe like if we had heard the vasculature was involved, maybe like granulomatous vasculitis, but because it's just parenchyma, I'd say sarcoid as well.
Yeah, it's sure starting to look like that, isn't it? The only point, so again, acute confusion, no one would have thought of sarcoid. Everything, there's no hint of sarcoid here. The imaging was sort of a non-specific appearance, and unless you're listing sarcoid just in the list of things that can do anything, the only place I saw in the imaging that made me say, oh, sarcoid can do that, was all of that inflammation at the midline and around the hypothalamus. I have a very memorable patient who presented with thirst and headaches and sleep difficulties, and had this sort of very, I think, and an optic neuropathy. I think we wrote this case up with the residents. I can try to dig it up. And had this sort of midline inflammatory, very kind of thick, packy meningitis there around. And I remember Marty Samuels and others just saying, flashbulb, this is sarcoid. I said, sarcoid can do that. I said, that's a very classic kind of sarcoid presentation. That was the only place where that seemed like something that would rise higher on the differential until the biopsy. So is it sarcoid, Doug? And how did you prove that? So I guess we would try to, either we would know from this, or we would say, hey, let's do some body imaging and see if there's other evidence to corroborate it. The ACE, both in the serum and the CSF, is very insensitive and non-specific. So what happened next, Doug?
So the crux of this case came from a re-review from a neuropathologist. So throwing credit where credit is very much due, but this case was unsolved for many weeks. There were many stains and like extended cultures and UPCRs and MNGS on the tissue that was pending at the time. The patient had to leave the hospital for social and personal reasons. The plan was for follow-up. We got word that he was doing somewhat worse at home, actually on a steroid taper for presumed vasculitis of unknown etiology, but also was having brain swelling and was worsening. So he was given a dose of or given a course of steroids. When it was re-reviewed, there were still marked granulomatous changes, but also noted multiple atypical cells, some located within the granuloma, some within the granulomas, and some had a round cyst-like appearance. This was concerning for amoeba forms in the context of severe granulomatous encephalitis.
Mario.
I'm going to have to say I almost swallowed my tongue when certain things were mentioned, but I'm not surprised given the brilliance of this audience and these discussants. But we reached out to the outside lab that does not typically send UPCR for things for specific amoebas, but we had them send that because of concern for acanthamoeba versus Naegleria versus Balamuthia, and the UPCR came back positive for Balamuthia mandrillaris.
Oh my goodness, Mario, Balamuthia, granulomatous amoebic encephalitis. This would be my first case hearing about an actual case of this. Oh my goodness. Have you guys published this case?
This case is it's too recent to have been published. It was diagnosed about 4 days ago.
Oh my goodness. Thank you so much for bringing this case. I am speechless. What a case. And for those who have time and interest and can stay, I would love to hear, Doug, how, if this case was sort of signed out as granulomatous and did the pathologist say consistent with sarcoid, and the team, I mean, none of us feel that comfortable, although neurologists have to do a few months of neuropathology and residency, as Doug can attest. You never get very good at it, at least I didn't. Good enough to argue with the pathologist the way we argue with the neuroradiologist. Was the case signed out as sarcoid, accepted as sarcoid, and the patient kept getting worse on steroids, or the pathologist kept mulling it over and someone came up with this? How did you get from a premature closure to this diagnosis?
I'm not exactly sure how the re-review happened. I think it may have been through something internal to the pathology department of reviewing interesting and unclosed cases. But the thought was this was some kind of granulomatous inflammatory disease, infectious versus autoimmune. As I said, none of these studies for endemic mycoses, which were very high on the differential, atypical bacteria. We had a great ID consultant presence. all of those things came back negative, and in the setting of a patient who was, getting radiographically worse, and had gotten an initial dose of steroids and hadn't gotten worse on the steroids. He was given steroids, and the plan was to follow up some of these extended microbiological tests on the tissue and some of the remaining CSF studies in the outpatient setting. But we probably would have kept him in the hospital to watch him longer if we could have, but we couldn't. So, we went back and we got some more information about this. This patient is, turns out works in construction, is very into, spends a lot of time in the woods, has had extensive soil exposure, has had extensive animal exposure, lives near farms. We got some of this information from extended family once we could reach out to them, and he is being treated. So we consulted the CDC on this case, and he's being treated with, I guess you could say, quintuple therapy. But this is a very morbid diagnosis, unfortunately, for the patient. But some of the cases that have survived have been treated with, a cocktail of very, very potent antibiotics.
And why did Mike Wilson think no Balamuthia genetic fragments turned up on metagenomic sequencing?
I can't answer that question, but I have the same question, and I think that's being worked out.
Wow. Yeah, this is something that comes up because it's a cool sounding name and is a rare infection, but I've never heard of a case even secondhand, let alone firsthand. So round of applause for Mario for saying, is that skin lesion, which we don't know if that was actually Balamuthia also, but I think they can get skin lesions, for thinking of, could this be Balamuthia from the very limited data. That is extraordinary neuroinfectious disease clinical reasoning. And both Mario and Maria, brilliant clinical reasoning throughout, right? Thinking about the brain mass, is it relevant or not? It was very relevant, but it was not, as Doug said, you get to a consult for brain mass in 3 hours, and in real life, 3 weeks later, you find out this is actually Balamuthia, right? But the approach to a brain mass, the approach to different potential infection hinting clues here, right? Although none of them were actually the ones, except the dirt under the fingernails, maybe, right? But a lot of people have dirt under their fingernails. So fantastic, my goodness. Well, for anyone who is still here with us, which is 25 out of 30, which isn't bad. Kirtan, what are your reflections watching us wrestle through this case?
Yeah, sure. So Doug, thank you so much for presenting this case. Thank you to Aaron, Maria, and Mario for discussing it brilliantly. And since it was not first Tuesday of the month, I guess time was not the issue. So it kept on and on. So I will try to keep it brief. So first we started with the brain mass. So Maria pointed out that what it actually signifies. I mean, is it a tumor? Is it an abscess or some autoimmune disease which mimics the mass? So we have to differentiate amongst all this by characteristic imaging findings, all the sequences, and the location. So whether it is intraaxial, whether it is extraaxial, supratentorial, infratentorial, and we have to consider the law of proportionality. So could it be metastasis? Could it be primary tumor? All sorts of things. Then we get the past history. So as always, there are red herrings in past history. So we were considering the endemic mycosis. We were considering the possible complications of alcohol use disorder and maybe comorbid drug abuse. So that led us to thinking about infective endocarditis, some sort of brain abscess. But then another thing which Aaron and Maria pointed out, that what if we see through the haze? If we just consider the fact that the patient had confusion, acute onset confusion, then straight away, first thing that comes to our mind is infection, right? So what infection this could be? Is it some form of meningoencephalitis? So that was, a pivot point there, that what if this is indeed a meningoencephalitis and we are just worried about this slurred speech and we are just worried about possible facial droop and seizures, but we have to focus, we have to see through the haze. So if we zoom out and if we took the bigger picture, then we realize that three things: stroke, seizures, and infection can explain all of this if we take context into the picture. So if a stroke is in particular location, then it can explain the confusion. If the seizure is in particular area, then it can explain the confusion. And meningoencephalitis itself, being an infectious process, can explain the confusion. And then finally, if we put the imaging studies, CSF and biopsy picture in the perspective, and midway through the case, Mario pointed out that what if this is indeed, an amoebic encephalitis, And then Ravi told us that how fresh water and soils are linked to it. And then retrospectively, as Doug mentioned, that the patient had exposure to construction sites and everything. So it makes perfect sense that exposure to soil can lead to this granulomatous encephalitis. But I guess the takeaway message is that, as all of you know, that I am a big fan of medical fiction. So I watch House MD and everything. So in House MD, always it happens that they give the treatment, and based on that, they try to figure out what's the cause. So it is basically what happened in our case. We gave the steroids presumably because of vasculitis or amyloid angiopathy or sarcoidosis, but the patient wasn't. So that is what House does every time. He gives some treatment, it doesn't work, then he changes the treatment. So actually that was what led to the final diagnosis in this case, because we think it was inflammation, but then pathologists and everyone thought that let's take a step back and re-examine everything. And then we find the evidence that it is indeed an infection. So amazing case, and I learned a lot. And thank you so much for that. And Aaron, do you have to share anything with us in the last?
Brilliant synthesis, Kirtan, of some of both the tangible, practical teaching points of the actual things we discussed versus some of the broader sort of clinical reasoning aspects. No, I'm still just awestruck by the case and the amazing discussion, and that this diagnosis was even mentioned. I think I've only learned about this recently, aside from hearing people listed in long differentials, because it just sounds cool to say Balamuthia. It sounds like some dinosaur or something like that. So thanks to Doug for bringing this fresh case and
freshwater case.
Freshwater, well played, for bringing us this case and presenting it in a way that allowed us to have a lot of interesting discussions, and probably a little front-weighted, so we didn't have as much time. Well, we had plenty of time, but not that everyone could stay in here to discuss the pathology and kind of the post-pathology aliquot, which is a rare thing to hear. So my goodness, we will all learn from this case of Balamuthia, which may be the first one we've heard of from a peer that will now stand in our minds in a very clear way. So thank you, Doug, and thank you, Maria and Mario, for an amazing discussion of this case. As Maria wrote, as we both saw in a song yesterday on Twitter, everyone duck those hands, duck those hands. Yeah, fantastic, and thanks for the teaching points, Kirtan. Thank you for the 24 out of 30 of you who decided to stay an extra half hour and debrief this case, and thanks to Ravi for the cameo on the epidemiology of Balamuthia and acanthamoeba. Wonderful. And I think last thing I'll say, the other organism that does not cause GAE but can cause a very fulminant meningoencephalitis is Naegleria fowleri, another cool name. That's the freshwater one that I think I've read about stories from a neti pot. I've also never seen a case. And as Doug said, there's obviously these are super rare, and you treat with 5-6 drugs of things we've never actually heard of, most of us, that are anti-parasitics, right, and antimicrobials and anti-everything, and just super toxic stuff. But the fact that this guy made it through steroids for a few weeks probably suggests that maybe you'll get this under control. So we'll love to hear feedback, and I hope, of course, you are publishing this case as something, a CPC, clinical reasoning, because people need to learn about this diagnosis, because even metagenomic sequencing and pathology missed. Maria says I have to review my illness script. Yes, mine is a blank sheet of paper. Okay. Last word for Doug, anything?
Oh, I was just going to say, I have to thank my friend and all of our friend Dan Minter, who's a beloved CPS leader, but also a neuro or an ID fellow at UCSF, who is working on this case as well, and sent me his Evernote on the 3 free living amoebas, which is Naegleria fowleri, acanthamoeba, and Balamuthia, and he grouped them into 2 syndromes. The first being primary amoebic meningoencephalitis, which is PAM, which is more of a diffuse, very fast-moving, almost invariably fatal meningoencephalitis that's very multifocal, which is typical for Naegleria fowleri. And then the GAE, as Aaron mentioned, granulomatous amoebic encephalitis, or as many people mention, which can have this mass-like appearance. When this person first came in, we thought, I looked at it for a brief second before I was on the move at the time and said, oh, maybe this is a glioblastoma. just, given where it is. The enhancement pattern was a little weird. The, lack of mass effect was very weird. So, and I said, there's certainly a Barter differential, but, tumor is certainly high up there. So this has really refined my thinking about discrete focal brain masses as being, you can have just a big ball of granulomas that has a broad differential, but can certainly be parasite in the absence of any eosinophilia, in the absence of any peripheral signs, and no great signature on the CSF. So that was a big learning case for me. But those two syndromes are big takeaways for me.
Yeah, exactly. And I think that granulomatous amoebic encephalitis, that GAE, is a bit of a misnomer, right? Because the syndrome is an encephalopathy, but the imaging, encephalitis, we think is sort of a focal area of inflammation. This, at least what I've read in case series and reviews, is multifocal enhancing lesions, right? Which is not sort of, I guess it is encephalitis, right? The brain is inflamed, but kind of has a different connotation, doesn't it? So granulomatous amoebic multifocal ring enhancing, I'm sure we could find a good something, some catchy mnemonic like press or something that just catches on there. Because I think encephalitis sort of, you would think, having just heard that, right, that the patient would have something that looks more like what we would think of encephalitis, that there may be a little enhancement, but not mass lesions, right? The other one I think of as neurocysticercotic encephalitis, a super rare variant, more common in young girls, where there are just tons of, it's miliary neurocysticercosis. Basically, they're just innumerable lesions, and the presentation is encephalopathy, but it's multifocal. I don't know if that bothers you, Doug, as a fellow neurologist and by nature of being a neurologist, also very interested in precisely describing syndromes and semantics. But I think that's an interesting point. And the other point is that we usually don't think of an illness script for pathological finding, right? And we all said granulomas, TB, or sarcoid, right? But to think that if we were writing an illness script or a schema, right? A schema for granulomatous brain inflammation, right? That we would have to include this, so we didn't forget to remember to think of this, right? In the next one. And Robbie, as Maria is saying, probably already has this schema somewhere in his library. Any thoughts on that, Doug? We'll see. We'll keep going until the participants go down to 2, just me and Doug.
No, I don't have much. Once we had gotten into the granuloma land, we were very much in rheumatologic, atypical bacteria, endemic mycoses. I can't say I know that parasites were mentioned. They certainly weren't mentioned by me when I was the consultant on the first time around. It was not on my radar that this about having a parasite. We knew he was immunocompetent, but Naegleria. I think acanthamoeba can cause GA, or what's called GAE, in almost exclusively immunocompromised people. And forgive me if I'm getting that wrong, but Balamuthia is the one that affects people who are immunocompetent and or immunocompromised. So that was not on my radar. We talked a little bit about focal presentations of primary CNS vasculitides, which can have very, very rare, PACNS can very rarely present with a presentation. We thought a lot about that. Certainly sarcoid and rare related vasculitides related to autoimmune disease. But that workup was negative and unrevealing. So, and then one of my attendings actually told me that he had seen a presentation of methamphetamine-induced vasculitis, which is usually a diffuse process that was also mass-like. In his experience. I don't have the imaging or the full story on that case yet, but it was something we thought about on the front end, because he did come in, he was amphetamine positive, which contributed to the initial altered mental status. To your question about encephalitis, Aaron, sometimes, and maybe this is too broad for me, but I think about, when do you go from meningitis to encephalitis? And I think of it, you start with the CSF, and if you have inflammatory CSF plus something like seizures and persistent altered mental status, I call it an encephalitis. But so that didn't bother me too much, but I know that's certainly a controversial line to cross in terms of definitions.
Well, this is an interesting situation where the infectious disease doctors, sometimes you'll hear them giving morning report or a CPC, and they'll say, well, these are the bugs that cause meningitis, and these are the bugs that cause encephalitis, and those are separate syndromes. But as Doug said, patients with meningitis can be confused and seize, and probably the brain is inflamed also. So meningoencephalitis, you can have isolated meningitis, you can have isolated encephalitis, but you can commonly have meningoencephalitis. It's interesting that vasculitis came up. I wondered from another type of bias. Doug knows that I'm very skeptical of the diagnosis of primary CNS vasculitis. I believe that it exists, but that it is exceedingly uncommon. In any case I've seen that's held that diagnosis, it's ultimately been debunked on pathology, and colleagues and I have written about this being very, 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 very uncommon. I have not seen a case in what is it now, almost 12 years of doing this. So I'm sure they're out there, I believe that, but it's often misdiagnosed. So I thought, as a bias, since Doug knows I feel this way, that he was going to give me a vasculitis case to show me that it's out there. And it can cause, that's part of why it's hard to diagnose, it can cause a mass lesion. But gee, yeah. My understanding with Balamuthia and acanthamoeba, I think from the literature, is that acanthamoeba tends to be a little milder, is sort of the only distinction I make, that patients tend to do better. I didn't realize a distinction between immunocompromised and not immunocompromised in those two, but this is from cursory reading. When I said Balamuthia, what's that? I'm looking it up.
Well, I'll put out a plug for the new I would say episode, the new issue of Continuum by the American Academy of Neurology is neuroinfectious disease. I think the digital version is available now for members, but our own Aaron Berkowitz played a huge hand in that and wrote the introductory approach to neuroinfectious diseases article, which I think I read the first day I could read it, and it was fantastic. It mentions Balamuthia, and I was also involved in, I think, the meningitis chapter, and it's fantastic. It's a tour de force, and something I'll go back to many times. So I highly recommend it to everybody, and thank Aaron for that.
Well, that's very kind of you, Doug. It was a lot of fun to work on, and I learned a lot. And as you can see, as Doug mentioned, I was just going to say also, even mentioning Balamuthia and acanthamoeba and Naegleria in my introductory article on general types of pathogens to consider in neurologic infections, and reading about them for that doesn't mean you will recognize it when you see it, right? So this is the Osler quote, right? That's in Reza's book about being with books only and no patients is like the ship docked in the harbor, and you don't see any patients until you don't go out to sea until you actually see the patients. So this interface between reading and studying and seeing these cases, right? For Doug, this will always be burned into his mind, right? That he's seen a case of this and will make the diagnosis someday, next time in 20 years, or in every CPC wonder if, because he's going to publish this case, they're presenting him another Balamuthia when it's not. So the double-edged sword, right? But that interface, if I'm someone who actually just, as Doug said, guest edited an issue of a journal on neuroinfectious disease and wrote about this entity and still didn't recognize it here, right? So it just shows you the need for the constant interplay between our studying and seeing lots of patients, or talking about them with colleagues like Doug, who is clearly at the epicenter of interesting neurology up there in San Francisco.
This case also, I would say, represents the majesty of having an international discussant group, and just makes me appreciate what we can learn from our international colleagues every day. So thank you all for being here.
Yeah, this was phenomenal. And we may have broken the record from Kirtan's previously held record in a patient that had both NMDA encephalitis and NMO, which, so I thought it was reasonable to have 50% more discussion time because there were two major diagnoses. All right, 19 out of 30, we'll keep going. Just kidding. Thank you so much, Doug. Amazing case. Thank you for sharing this with us. I will think differently about how I budget my time, or ask you for how many aliquots after the imaging next time. This is amazing. Mario, Maria, great job. Kirtan, great job. Thank you for all of us who spent an hour and a half plus with us discussing this case. I can't imagine my day getting any better from here, and will enjoy continuing to think about this case and what a wonderful time we had together. Thank you, everyone.